Hi, my name is Phyllis Clement. I'm a caregiver for my husband, Pierre, who was diagnosed with MG in 2015. MG symptoms began soon after we were in a car accident. We were hit by a drunk driver. Pierre got 6 broken ribs. That is when my role as caregiver began. Once his ribs healed, he started having trouble with his vision. First, only double vision, occasionally. He kept these symptoms to himself. I began to notice a droopy eye. One of the many responsibilities of a caregiver is to watch symptoms and track symptoms. We still did not know what was happening. As most do, we went to the eye doctor. Soon, symptoms began to increase. His speech started to slur, especially when eating. Thinking this could be a stroke, we ran to the ER. There, a nurse noticed all the symptoms and said, "I think he could have myasthenia gravis." This is where our official journey began. His speech got worse, and it was hard for him to swallow, eat, or drink. He started to drop weight. We met with a neurologist who told us many different treatments. We started with the simplest medication one at a time. We would eliminate them after months of trying them until we found one that really helped. We wondered if we would ever find a treatment that would work. It took a while. We learned that others may have MG, but it doesn't mean that the same things, the same treatments will work the same way on everyone. IVIG was the thing that really helped. June of 2016 was his first IVIG treatment. There was a time when I wasn't sure if I would ever hear his voice again. It was my job to stay strong and keep track of what was happening and what we were doing for it. We carry a journal to every doctor appointment and every treatment. I have this book to look back on now. His voice did begin to return after January of 2017. We attended support group meetings, not only for him, but for me to talk to other caregivers. Many helpful suggestions and many lifelong friends have been made from these support groups. My job as a caregiver was also to help with all the insurance issues that come up. I tried to take everything that caused stress off his plate. We were denied IVIG treatments for some time due to the insurance, saying that this treatment was for crisis situations and not for maintenance. It was the only thing that worked to keep his MG at bay. We fought long and hard, and finally, after missing a couple months along the way and his MG increasing, we got approval for IVIG as an ongoing therapy. We finally convinced the insurance company, with the help of our doctors, that they could pay for this maintenance treatment, or they could pay for ICU when he goes into a crisis. He had his treatments in our home for a while. It even happened that I had to step in and help with the treatments for the nurse. A nurse would come and start the treatment, and then I would have to fill the bags of the medication, change out the bags as they emptied, and at the end of the treatment, I would have to remove the needle from the port. This was something I thought I would never be able to do, but you do what needs to get done. The years have passed, and we've had our ups and downs with this disease. The IVIG continued to help with symptoms, but the insurance was still an issue. We decided to try a new infusion called rituxin. It only had to be given every 6 months instead of monthly. So on the advice of the doctor, we decided to try it. Again, frustrations with insurance approvals, added delays, and concerns of delays between treatments. The night of the first rituxin treatment after it was finished, and this was probably just a coincidence, he started to feel really bad. I couldn't reach the infusion center, so I called 911. They took him to the ER and determined that he'd had a heart attack. Once again, my role changed. I was still needed to be a caregiver and an advocate to help him through his open heart surgery with having MG. During the surgery, they decided to remove his thymus gland. The surgeon's assistant had researched MG and had suggested to the doctor that the thymus should be removed to help with his MG. He came home from the hospital and to recover from this surgery. He not only recovered very quickly, in my opinion, but all of his MG symptoms were gone. I continue to watch and wait for symptoms, but thankfully they have not returned. My job is not only to care for him, but to advocate for him, as with his doctors, the insurance company, and now Medicare. It is never ending, but I don't mind. We are in this together forever, as we will get through it together. We celebrated our 50th wedding anniversary this past September, and I look forward to many more. I received a book from a friend who went through being a caregiver for his wife with Alzheimer's. This book is called Coping with Caring by Lynn Roche. It is full of daily, 365 notes to help you cope. And I'm going to share just a few. First one is, I realize I do better when I deal with one day at a time. Today is a new day. I will focus on it and enjoy the ever-present now. There is much in this day I can take pleasure in if I allow myself. By not dwelling on tomorrow or obsessing over yesterday, I will be open to see how precious today is. Another one is, life is full of changes. Some we expect, some we don't. The people in our lives change. Right now, my life is full of changes I didn't expect and I don't want. I can't control them. Neither can my loved one. What I can control is the ways I face these changes. I will love myself and my loved one through these changes. That one's important. Here's another one. No one has all the answers. My caregiver friends don't. My doctor doesn't. I certainly don't. We all work together and we don't stop trying. We share new information. We share our frustrations, trial, errors, and successes. It's teamwork. Whether it's a support group, a family member, or friends, you need people to help you with this journey. It will help get you through it, hand in hand and day by day. Thank you.
All righty. I'm Caroline Boline, the National Director of Strategic Impact and Investment here at MGFA. And it is my pleasure to introduce you to Dr. Michael Rosario Prieto. Dr. Michael Rosario is a neurologist in St. Petersburg, Florida at St. Anthony's Hospital and is board certified in general adult neurology, electrodiagnostic medicine, and neuromuscular medicine. Dr. Rosario earned his Doctor of Medicine from Guadalajara, Mexico. He then completed a neurology residency at John Dempsey Hospital / Hartford Hospital, University of Connecticut School of Medicine, followed by the completion of fellowships in neuromuscular medicine and advanced neuromuscular medicine from Duke University Hospital. Dr. Rosario is a member of the MGFA's Partners in MG Care program. Please welcome Dr. Rosario.
Good morning. I'm excited to be here. Thank you for inviting me. Everybody had breakfast? Excellent. So let's go ahead and get started. These are my disclosures. And today we're going to talk about the treatment options in myasthenia gravis. We're going to learn about the old stuff. We're going to talk about the new stuff, about the upcoming stuff, and not just name all the medications in a list form, but I want you to understand how do they work and why do they work in your disease. And there are different treatment modalities in myasthenia gravis. We have lifestyle modifications, exercise, diet, etc. Pharmacological treatments. There are some interventional procedures and even surgical management with thymectomy. Today, we're going to be discussing pharmacological treatment and interventional procedures. From the pharmacological treatments, there's symptomatic management that will be with pyridostigmine, mestinone. There's also some immunomodulator agents like prednisone. There's some oral immunosuppressants, to name some, Celsep and Imuran. And then there is some IV treatments like Solaris, Ultomiris, Vigarde. And in the interventional procedures, we have emergent management, things like IVIG and Plasmapheresis. And for refractory management, there is experimental research going on with stem cell transplant. Let's start with the basics, which is pyridostigmine. But in order to understand mestinone, we need to know a little bit about the neuromuscular junction. Today is day 3 of this conference, so you've probably seen this picture a couple times. I'm going to assume you haven't, so I'm going to explain it. On the left side, you have your nerve terminal, your neuromuscular junction, and your muscle membrane. When we make a muscle contracture, either voluntarily or involuntarily, like blinking or breathing, electrical impulse comes down from our brain into our brainstem, spinal cord, into our nerve, and it ends here in your nerve terminal. That's step number 1, electricity coming down like this. Once it gets to the nerve terminal, there's a chemical reaction here with calcium, step 2. And after that chemical reaction occurs, this acetylcholine vesicles will release acetylcholine molecules into the neuromuscular junction. And those acetylcholine molecules will be floating and hanging around that neuromuscular junction until they find a free spot at the acetylcholine receptor. Once it binds to the receptor, there's another chemical reaction that occurs, and that eventually leads to muscle contracture. So that's normal physiology. Now, in this neuromuscular junction, where all these acetylcholine molecules are floating around, we have this enzyme that looks like a Pac-Man. This is called the acetylcholine esterase. And the job of this Pac-Man is to be eating away all those vesicles and all those molecules in the junction. This last picture right here, we have the MG antibody, which is the acetylcholine receptor antibody. And here is occupying this space in a receptor. So the acetylcholine is unable to bind. So that creates a blocking of the neuromuscular junction. So what does mestinone do? Well, mestinone will bind to this molecule right here, the acetylcholine esterase, that's eating away all those acetylcholine molecules in the junction. So it binds to it, so it shuts its mouth and it's no longer able to eat those molecules. When the acetylcholine esterase is not working, now we have a lot of vesicles. And all those vesicles now are able to gang up and scare and push away this receptor out of this antibody out of the receptor. That's called competitive inhibition. So again, mestinone, the way it works, it binds to the acetylcholine esterase. Now the acetylcholine esterase is no longer able to eat those acetylcholine. So now they accumulate and they will gang up and they will scare away the bad antibodies from the receptor. and that's how it works. It comes in 60 milligram tablets. They are scored, make it easier if you need less dose. There is a long-acting formulation as well called time span. This one, I use it a little bit less, but it's also used. It does lead to irregular GI absorption. So that takes away some of the predictability in the efficacy of the medication. There's also an oral formulation, and there's a solution that can be used either IV or intramuscular. Solution is mostly for patients who are unable to take oral. Let's just say, for example, you are admitted in the hospital, you can't swallow, then you'll get a solution. By far, intramuscular is preferred over IV. I have personally never used IV Mestinon. If there is no IM in the hospital, it can be used. However, a patient needs to be closely monitored because the IV formulation can lead to bradycardia, low pulse, low heart rate. And there's a conversion between solution and oral form that the doctor needs to be aware of. That's 1 milligrams of IM for every 30 milligrams of oral Mestinon. A bit more about Mestinon. Mestinon works at the neuromuscular junction. Okay. Mestinon does not affect the complement system, does not affect your B cells, your T cells, the production of immunoglobulin. So Mestinon is purely symptomatic, and this is not an immunomodulating medication. It provides temporary improvement in strength, starts working in about 15-20 minutes, and that benefit peaks at about 45 to 60 minutes. Then about 6 hours later, it kind of wears off. And we use that predictability to help manage patients. There's no long-term side effects. However, there are some temporary short-term side effects that occur while Mestinon is in your system. The response is often incomplete, and it's variable between patients, and the dose is individualized. The dose for you, madam, is not the same dose for you, sir. Everybody's different. Typically, we start with 30 milligrams 3 times a day. We might need more than that or less than that. And then the dose is advanced as tolerated. Most common side effects by far are GI, nausea, vomiting, abdominal cramps. Diarrhea is in capital letters. Also, you can have water coming out your nose, your mouth, your eyes. You can get muscle twitches and muscle cramps. Now, if you're having those side effects and you continue to take more and more and more and more Mestinon, you'll go into cholinergic crisis. Cholinergic crisis are the same symptoms above, but also your heart rate can go down and you can have worsening weakness. Typically, cholinergic crises occur at the peak of the dose, which is about 45 minutes-ish. This here is the wholesale price. It's not your price. It's the price the pharmacy buys it, and they upscale it and they up it times 2 or 3 and sell it to you. But what I want you to see is difference between the cost of brand versus generic. Here, Mestinon brand, a 60 milligram tablet is $23. In generic, 60 milligram tablet is less than $2. Okay. So if you're taking pyridostigmine generic, 60 milligram 3 times a day, that's about $5 a day. If you take Mestinon brand, 60 milligram 3 times a day, that's about $70 a day. You can see why some of the insurance companies push so that patients get generic over brand names, because the prices is significantly different. Again, Mestinon does not alter your immune system. That's a good news. Okay, it doesn't stop your immune system from producing antibodies, the good or the bad. But if mestinone is not doing it, if you're still symptomatic while on high doses of mestinone, or if you are still having symptoms and we're not at goal, then we move on to tier 2, which is the immunosuppressants. And I just said, if you're not at goal, so what is goal? What's the goal of management? Well, the goal of management is to keep you as symptom-free, possibly at minimal manifestation state. It's the state where you as a patient do not feel that you have myasthenia. Even though the clinician might see a little bit on an exam, you personally don't feel that you have it. That's our goal. And our goal is to accomplish that with the least amount of medicine as possible, particularly one that doesn't cause side effects or cause only minimal side effects. And if we can't achieve that, then we move on to immunosuppressant. But to understand how those immunosuppressants work, we need to know a little bit about basic immunology. And I wrote basic because this is going to be very basic. In our bone marrow, we have stem cells. And those stem cells differentiate into many cell lines. When your doctor orders a CBC, you see how there's WBCs, red cells, platelets, et cetera, et cetera. For the purposes of this discussion, we're going to focus on the B cells. Okay. And B cells differentiate into plasma cells. And the function of plasma cell is to spit out immunoglobulins. This is your plasma cell, and it secretes, throws away, or spit out these immunoglobulins. And there are many types, there's several types of immunoglobulins. We all know about IgG, is the most common. The myasthenia antibody, the acetylcholine receptor antibody, is an IgG. Most of the newer medications and most of the medications in the pipeline alters IgG. Okay, but IgG is not the only one. We also have IgE, IgD, IgA, etc. And they all have their little functions. IgG provides protection against bacteria, viruses, also activates the complement system. IgG helps us against worms and parasites. And IgA has a lot to do with mucous membrane like asthma, respiratory tract, etc. So here we have our B cell. Our B cell differentiates into plasma cell. Plasma cells secretes or spit out all these immunoglobulins, and then they see a bacteria around, a target, a pathogen, and they will bind to it. And once it binds to it, then this guy gets killed by different mechanisms. The complement system get activated, and many of the bad guys comes in, because the complement system is a system that calls out the bad guys. Hey guys, come here, we have an intruder, let's kill him. Okay, so that gets activated. They all come and they kill this guy, okay, the bacteria. So we have here a plasma cell that produce these good IgGs that targets the bacteria, etc. But in MG or in autoimmune diseases, this plasma cell is confused. It's now not only produces the IgG, but the same plasma cell, the same B cell produce the immunoglobulins that targets our own body. Those are called autoantibodies. And those are the bad IgGs, and they see our body as parts of our body as a pathogen. In the case of myasthenia, this is the autoantibody, and it sees the receptor here as the bad guy, so it binds to it. So the immunosuppressants, how do they work? Well, they eliminate the plasma cell, the B cell, by different mechanisms. They all have different mechanisms, but at the end of the day, the bottom line is we're reducing the B cells. So that means that it gets that plasma cells no longer producing or spitting up bad IgGs. And that's what we want in myasthenia, to not produce these bad IgGs, to eliminate them. Unfortunately, the medicines also make the cell not produce the good IgGs, the IgGs, the IgMs, the IgDs, all of them. So that leads to an immunocompromised state. So that's how it works. Eliminates the B cells, plasma cells. So now we are reducing our bad IgGs, thus improving myasthenia. Prednisone comes in tablet. There's also a liquid form. There's an IV form. Prednisone is relatively cheap. It's about $20 a day. I'm sorry, about $5 a day if you are on 20 milligrams daily. So prednisone is not expensive. So how does prednisone work in myasthenia? My doc put me on prednisone, I feel better. How did that happen? Well, prednisone here in yellow attaches to cells, many cells. In this case, it will be a B cell. And once prednisone attaches to the cell, it enters the cells, and it then will invade the nuclei, will go into the nuclei. Once in the nuclei, it will alter the gene expression. That nuclei has the instructions. Okay, the instruction of that B cell is to differentiate to a plasma cell to make antibodies. So that instruction is altered. Now the new instruction is go die. So now we have, it dies, goes away. So there is a reduction in B cells. That way, it reduces the amount of B cells, and the less B cells means less IgGs, the good or the bad. That's why it improves myasthenia weakness. That's also why it leads to immunosuppression, because it drops all Igs. It is highly effective. It doesn't work fast. It takes about 2 or 3 weeks to start working. Recommended dose is about 1 milligram per kilogram, particularly in generalized myasthenia. That's about 60 milligrams a day. Once you start that, you then reassess about 6 weeks into it, 4 to 8 weeks into it, you reassess the patient. And once improvement is maximal, once the patient is no longer getting better, once it's back to baseline, then we start tapering slowly. And that's a very slow taper. It might take a year. And when you're on those high doses of prednisone, you have to expect side effects. On your right side here, you have a manatee telling this little lady, this little girl, that manatee used to be small and thin, but they put him on prednisone. It's a funny picture, obviously, illustrating the side effect of weight gain, which by far is the most hated side effect by patients. Weight gain is not the only side effect. Also elevates your sugar, particularly if you're diabetic. It can turn you into a diabetic if you're not one. It can affect sodium metabolism, so you retain sodium. With retention of sodium comes fluid retention, also high blood pressure. It can also secrete into your kidneys, and you can pee away potassium. If your potassium is low, that can cause cardiac arrhythmias. If your potassium is low, that can worsen myasthenia. It can also cause dysphoria. Dysphoria, meaning jitteriness, anxiety, mood swings, personality changes. Long-term use of prednisone leads to skin changes, easy bruising, also acne, poor wound healing. There's increased risk of infections. We already explained why. Weight gain, osteoporosis at long term. Avascular necrosis, which is probably the most feared side effect from clinicians. That's like a bone infarct. Most common place is your hip. So if you're on prednisone and all of a sudden you start having severe hip pain,
Make sure you tell your doctor you're on prednisone. You'll need some imaging. Cataracts at long term. You can also get nausea and peptic ulcer disease, etc. So it works, it's effective, but at a cost. Once we start mestinon, and we're not at goal, and we're at high doses, or we're having side effect, we move on to prednisone. We start high doses. Once you get better, we start tapering prednisone off over a long period of time, very slowly. But if we're unable to taper that prednisone off, then we need to move on to kind of the next tier. And these are some of the immunomodulator or steroid tapering agents. And here's a list of a few of them, like Cellcept, Imuran, Rituxan, Soliris, Ultomiris, Vigarde. Which one would you choose? Well, that's a conversation. It's not an easy answer. I'm happy there are alternatives. But the more alternative, the more discussion. It all depends on the side effect profiles, convenience to the patient. Some patients don't want to take anything oral because they already have 30 oral meds. Depends on comorbidities. Also depends on the severity of the disease. Some of these medicines, for example, Imuran, they take many months to start working. And if we want fast action, we're better off one of the agents that produce faster improvement like Soliris or Vigarde. At the end of the day, it's all about the insurance. The insurance will tell me what to prescribe you. Okay, that's just the bad news, but it's the reality of how it works. Briefly on Rituxan. Rituxan is a monoclonal antibody against CD20. What is that? Many of the medications, the current ones like Rituxan, Vigarde, Ultomiris, and many of the upcoming medication, they are monoclonal antibodies. We talked about IGGs. These are antibodies that our body makes. But monoclonal antibodies are antibodies that were made up in a lab. They were engineered in a lab. And those antibodies have specific instructions to target something. In the case of Rituxan, it targets CD20. So we have up here our engineered monoclonal antibody Rituxan, and it will bind to CD20. CD20 is this little protein that is sitting on top of the B cell. Now, the function of CD20 is to guide that B cell around. Same way a jockey will guide a horse around, the CD20 just kinds of driving that B cell to places. And if Rituxan is targeting and eliminating the CD20, then that B cell does not know where to go. And that will lead to cell death destruction. So without a properly functioning CD20, the B cell dies. And when the B cells die, it does not produce immunoglobulins, any of the immunoglobulins, the good nor the bad. Okay. We use it in MuSK. We use it in refractory generalized myasthenia. We don't use it in ocular. The side effect profile the risk does not outweigh the benefit in terms of ocular myasthenia. It leads to significant immunosuppression for long period of time. That's why it's performed every 6 months. It's intravenous and costs around $12,500 per infusion. That's about $20,000 or $30,000 per year. Soliris or Ultomiris, to understand those, we need to know a little bit about the complement system. The same way the French fries complement our burger, the complements, our immune system have this complement proteins. And the job of this complement proteins, they don't kill, they don't attack. What they do is there's a snitch. They're the ones that call out our immune system and tell them, hey guys, come here, we have a problem. Okay, so they signal traffic, same way the police officer signal the traffic in a street light. They will signal traffic to the immune cells to tell them, here, this is where the problem is, kill this guy. Okay? So that's our complement system. And in this picture, we have the muscle membrane with the acetylcholine receptors. And now we have our myasthenia antibody, the autoantibody. And once the autoantibody binds to the receptor, it activates the complement system. And now the complement system is calling our immune cells to come in and attack our muscle membrane. When it attacks our muscle membrane, now we have a simplified membrane with loss of its architecture, loss of structure. The receptors are not working properly, and now we have a problem. So what Ultomiris does, it's a monoclonal antibody. They made it in a lab, and this antibody will now target this complement. And once it targets the complement, pretty much make them useless. And now they can't call our immune system to come in and attack our membrane. And that's how Solaris and Ultomiris work. Notice that they work on the complement system. They do not reduce, those two medications do not reduce our ability to form IgGs or any of the IgGs, does not reduce the number of IgGs or B cells. So it's not an immunosuppressant medication. Because it's not an immunosuppressant medication, you can actually use it in conjunction with an immunosuppressant medication. And it's one of the most expensive medications out there. It could be about $500,000 a year. They're both IV. They have the same mechanism of action. The efficacy is the same. Main difference is that Solaris is every 2 weeks and Ultomiris is every 2 months. They are FDA approved for adults who have generalized myasthenia gravis, who have the presence of acetylcholine receptor antibodies. It's not for MuSK. Actually, the MuSK autoantibody do not activate the complement system, so these medications are not expected to help in myasthenia. And for both of these medicines, we need the meningococcal vaccine 2 weeks prior to treatment. The complement system is the responsible one to get rid of the meningitis bacteria. That's why and all bacteria with capsules. So that's why we need to get this vaccination before the treatment. Next one is Vigarde. To understand Vigarde, we need to understand and learn about the concept of IGG recycling. Again, these are plasma cells coming from our B cells, making all the immunoglobulins. And Vigarde affects this guy here, and there is no reduction of this guy's. Okay, so it's not an immunosuppressant because you still have IgEs, IgDs, IgAs, IgMs around. It lowers IgG only. And our body makes immunoglobulins, but our body has to get rid of them also. If we make immunoglobulins and we don't get rid of them, then our blood is going to be very thick and we're going to be stroking out. So the body has a mechanism that after several weeks, the immunoglobulins have to degrade and go away. And that's done through some enzymes called the lysosome. And the lysosome degrades the IgGs after several weeks. However, not all the IgGs are degraded. Some of them, they get a second chance to live, and they will be thrown away into circulation. And that's called IGG recycling. So just think about this for a second. If your lysosomes, if your body is not destructing all of the IgGs, only a few of them, and some of them are thrown back into circulation, well, that leads to a really nice, robust immune system. That's good. But if you have myasthenia gravis, you want to get rid of those bad IgGs. You don't want them back into circulation. That defeats purpose. We want them out. So that's where Vigarde comes into play. This is a picture. On top, that red tube is a blood vessel. And in that blood vessel, we have normal IgGs in white and black. We have the myasthenia IgGs or myasthenia antibodies in yellow. And after several weeks of being circulating, our body gets rid of it. How they come into this circle here is an endosome within body cells. And when they're here, they will attach FcRns. The ones that get attached to FcRn, they will have a second chance to life, and they will go back into circulation. But the ones that were unable to find an empty FcRn, they will be degraded by the lysosome. That's normal IgG recycling. So in this example, you have here two bad antibodies, MG, and through this IgG recycling, one bad one went back into circulation. You don't want that. You want to get rid of them. So Vigarde is a antibody that was made in a lab, and it targets the FcRn. And if those FcRns now are occupied by Vigarde, that means that more of these IgGs are going to be free. They didn't find the musical chair. They didn't find that free chair there. They didn't find the FcRn. And as we just talked about, those unbounded IgGs will go into the lysosome and will be destroyed. The ones that were bounded, they will go back into circulation. In this case, the two MG antibodies were destroying the lysosome and none was thrown back into circulation. So that way we have a reduction in IgGs, and that's part of the treatment. We want to reduce the amount of bad IgGs, the myasthenia antibodies. That's how Vigarde works. It binds the FcRn receptor. So the antibodies, both the good and the bad, they do not get recycled back and they die in the lysosome. As I said, does not eliminate all the IgGs, just a few. That's why it's not an immunocompromising medications. And it does not alter all the other IgGs, just all the other immunoglobulins, just IG. All the other IgGs are not affected and they're still functional. It's FDA approved for adults, seropositive, and generalized myasthenia. It's an IV medication. It's once a week for 4 weeks. That's a cycle. And subsequent cycles can be administered as needed. And the time between one cycle and another cycle varies between patients. It does not require vaccination prior to the treatment. Most common side effects are respiratory tract infections, headaches, and urinary tract infection. The cost is about $230,000 per year. Now, last month, it was published that subcutaneous form of Vigarde is not inferior than the IV form of Vigarde. So that's a plus. There was a phase 3 trial on the sub-Q that has been closed. So now we're waiting for results. So that's just a step closer to FDA approval if it happens. Plasmapheresis is not a medicine, it's a process. It's a treatment where you get hooked into a machine, you get an IV line, that blood comes out of your body, goes into a apheresis machine, into a centrifuge. A centrifuge is this guy right here where it spins the blood and it separates them It separates the cells from the plasma, just like this. We have the cells and the plasma, the cells and the plasma. Once it separates it in the cells and the plasma gets thrown away and the cells come back into circulation. And that's called plasmapheresis. So why do we want to get rid of that plasma? What's up with that plasma? Well, that plasma, that's where all the IGs live at. Also, the factors that makes clotting in our body lives there also. That's why one of the complications is bleeding. So how does plasmapheresis work? It removes the MG antibodies by removing the plasma from your body. When you remove the plasma from the body, you're removing the bad antibodies, and that leads to improvement in neuromuscular. That leads to improvement in myasthenia. It is very effective. Typically, 5 exchanges. You may do more. Onset of improvement during the process, it's variable. I see it often after about the 3rd exchange. It is short-term improvement. Okay. It lasts several weeks, so we need a backup plan whenever we're doing plasmapheresis. You get plasmapheresis, you'll get better, but 3-4 weeks later, you're going to go back to square one if there's no backup plan on your management. It's indicated for MG exacerbations, for MG crisis, sometimes used before surgeries for preparation. Sometimes, not the norm, but sometimes exceptions, we can use plasmapheresis as continuous management in cases where there's contraindication with all the other medications. You cannot have plasmapheresis if you have an active infection. If your blood pressure is low, you can't have plasmapheresis. When you take blood out of your system, your blood pressure is going to go even lower. You can have side effects just from a central line placement. Okay. The central line can collapse along. The tip can irritate the heart and cause a cardiac arrhythmia, and that line can get infected. You can have complications from the procedure itself, like low blood pressure and bleeding. If you get hospitalized with a myasthenia crisis and you get plasmapheresis, the bill is going to be about $100,000. That includes hospital cost, nursing, cost of blood products, physician fees, cost of complications, etc. So it's expensive. IVIG. These are immunoglobulins. Okay. They're administered intravenous, not oral, not intramuscular. That's why the IV before the IG. And each of these bottles are made up of thousands of donors. Okay. And they make this super concentrate collection of antibodies. In this picture, we have the nerve terminal, the acetylcholine vesicles. We have the muscle membrane with the acetylcholine receptors. And here we have our B cell producing the good IGs in orange and the myasthenia IGs in teal. This guy wants to reach this guy. So now we get IVIG, we're hooked in the machine, IVIG comes in, and this is what we think happens. IVIG will neutralize or will bind this bad IG and will prevent it from reaching its organ, its target. Not only that, recall the complement system, the one that calls the immune system and say, hey, let's attack this member right here. Well, IVIG also neutralizes the complement system so that it doesn't call out the cells to destroy our muscle membrane. So that's how we think IVIG works, binds to bad antibodies so they don't reach their target, and also inhibits complement activation. IVIG is also a short-term treatment, wears off after a couple of weeks, indicated in MG exacerbations, MG crisis, sometimes surgical preparation if patient can't get plasmapheresis. Sometimes we can also use it as maintenance whenever there's contraindications or refractory to other medications. Again, this is an exception, should not be the rule. And the initial dose is 2 grams per kilogram over a couple days. And if that were to be continued, the dose is 1 gram per kilogram over a day. If you get hospitalized with an MG crisis and you get IVIG, the bill is going to be about $50,000. Now, if you need IVIG maintenance and ongoing IVIG treatments as an outpatient, the cost is about $20,000 a year. And the cost varies depending on the brand, on where is it administered. Is there a nurse that comes to your home, or you get it in a hospital-based place or at an office-based infusion? Also, there's transportation costs, there's other medications costs, complications, etc. IVIG is a multi-billion-dollar industry. It's about $10 billion a year market and projected to be a $21 billion by 2023. So it's expensive. It's not just expensive, but it's also used in many other conditions, many neuromuscular conditions, and many non-neuromuscular conditions also require the IVIG. Contraindications: if you have IgA deficiency and you get IVIG, you could get an anaphylactic reaction or a bad allergic reaction. So your doctor will be checking IgA levels before starting IVIG. Also contraindicated in kidney function, in kidney dysfunction, renal failure. IVIG is a thick solution, so it will make your kidneys work harder. Also, because it's a thick solution, it will make your heart work harder. So if you have heart failure or your heart is weak, IVIG should be avoided. Finally, should be avoided if you have a history of blood clots, stroke, heart attacks, etc. Some of the severe adverse effects are anaphylaxis, renal failure. We talked about blood clots. You can have headache that resembles meningitis, and some of the other less morbid side effects are headache, hives, nausea, flushing, fever, and those side effects can be mitigated by reducing the infusion rate. Also with administration of medications prior to your IVIG. Subcutaneous IG, it's called Hizentra. That one is not approved for myasthenia, but there is ongoing studies on it. It's investigational. There was a phase 2 trial that showed it was well tolerated, safe, and efficacious in mild to moderate MG exacerbations. There was a recently completed clinical trial, and there's an open trial for MG exacerbations. This one is administered weekly and cost is about $3,000 per treatment, about $150,000 a year. Finally, this is purely experimental. There's research on this. This is stem cell transplant. There's actually an ongoing recruiting clinical trial. It's meant for refractory myasthenia. Refractory means nothing works. There are published case series on patients who have responded that are seropositive. There are case also reports on seronegatives and also in MuSK. How this happens is you get a bone marrow biopsy. That gets into that centrifuge. It removes stem cells. They freeze the stem cells. Then they radiate the stem cells. They put chemotherapy in those stem cells. And then they go back into your body in hopes that this new rejuvenated stem cell will differentiate into different cell lines that are not confused and making the bad antibodies. Almost done. In this picture is a diaphragmatic picture of pretty much all the MG medications and their mechanisms. On the right, you can see the neuromuscular junction. That's where mestinon helps by increasing the amount of acetylcholine so that they can push away the bad antibodies from the receptor. These are the bad antibodies here. And you can eliminate the bad antibodies by doing plasmapheresis, or you can bind to them, to the bad antibodies, so that they don't reach the target by doing IVIGs. Recall the complement. Complement is the one that calls the immune cells to kill. Well, IVIGs and Soliris or Ultomiris will affect that. Next step, remember the FcRn. We have Vigarde that binds to the FcRn. So now the MG antibodies are eliminated through the lysosome and they do not get recycled back. Remember the CD20, which is, it's on top of that B cell. It's driving, like the jockey and the horse, driving the B cell around. Well, we have rituxin that affects that one. We have some of the immunosuppressant medications. We have the thymus. We did not discuss this, but it's in the picture. So thymectomy, removing the thymus, is another way of treatment. And finally, we have our bone marrow, which makes all cells, all cell lines. You can do bone marrow transplant. Last slide. Pipeline. There's actively recruiting clinical trials in the United States. These are it. There's worldwide, there's more also. It's exciting that this slide is full of information. There's a lot out there. There was a time where there was not a lot of stuff, but just stay tuned. I'm hoping that soon we'll have more in our tool bag to help patients with myasthenia. Vigarde currently being looked into the pediatrics, so that's an option for pediatrics. We spoke about stem cell transplant. There is clinical trials on this. We talked about subcutaneous IG, Hizentra. They're looking at acupuncture also. This particular one, the first one, is including musk, and it's an anti-CD19. Recall rituxin is an anti-CD20, but this is very similar. This second one is also adults and pediatrics, so more options for the pediatric population. This one right here, the fourth one, it's a subcutaneous form of FcRn. It includes seronegatives. So if you're seronegative and want to participate in a clinical trial, this one is recruiting for seronegatives. You have CAR-T for musk and also for discarded 8, which includes also seronegatives. So there are some clinical trials including seronegatives. This one is an IV complement inhibitor, just like Soliris and Ultomiris. And this next one is a subcutaneous complement inhibitor. Ultomiris comes in subcutaneous, but it's currently not FDA approved for myasthenia. And it's my understanding that there is some clinical trials in patient myasthenia for the sub-Q Ultomiris. And this last one here is for seropositive MuSK and LRP4. So stay tuned, it's exciting that we have so much in the pipeline. And thank you for your attention. Yeah, questions?
We can take a couple questions. Did you have your hand up?
Hey, real quick question. You mentioned that there's a path of drugs that you wanted to take and how you have to wait for the insurance to approve rather than you, the doctor, right? Are we considering, instead of having to follow that path that we've had to follow, first Mestinon, then prednisone, yada, yada. When now we have some newer medications, what is stopping you, other than what you mentioned about the insurance, of going straight for some of these other medications that are showing great results?
Bottom line is insurance. Most insurance will not approve those medications without trying Mestinon or prednisone first. Also, many patients, we start on prednisone and we're able to fully taper them off prednisone and go into remission without the need to put them on on a chronic lifetime immunosuppressant medication.
But at a very big cost.
Yeah. Yeah, at a cost, at a cost. If insurance will pay for the other ones, that's for the other one without skipping prednisone, that's a possibility. Prednisone we taper. We know how to taper and we know it's effective. And the goal is to taper it completely off. If we see we can't taper it, then we use the other ones. So many patients we can taper off prednisone and they don't never need anything else and they go into remission, especially when it's the first time, newer onset. When you commit to these longer term medications, let's say Ultomiris, for example, just to name one, these are lifetime medications. There's not a tapering instructions for those medications. How, let's say you do well on it. When do we get you off it and how? We don't have instructions to do that. Right.
Probably just time for about one more question.
So to piggyback on what he was saying, it sounds like what we need is the farmers, the neurologists, and the patients to team up together and fight the insurance companies so that we can cut to the chase and get onto the new medications. Otherwise, not just the side effects, but some of these medications that you indicated could take 4 to 6 weeks, a year to kick in, when perhaps we could have gone on to Vigarde or one of the other medications. So I think from a patient point of view, MGFA, neurologists, and the farmers that are here, we need to work together with the insurance companies and say, stop, we need a better process. We need a better way to get to, otherwise, why should the farmers create this medication if it's going to take 2 years to get the very first patient on board? I don't know if that makes sense, but I'm just saying, I think he's right. And we need to pool together to get the process changed. Make sense?
Yeah, totally agree. It's a problem. It's a problem in all specialties. Whenever there's an expensive medicine, better medicine, more expensive medicine, there's going to be some pushback. Happens in the cancer world, happens in the multiple sclerosis world, happens in all. It's a nationwide problem. It's not a MG specific problem. It's just it's unfortunate problem. It's an economic, financial at the end of the day. All right, thank you.
Thank you.
We do this, we gotta.
Oh, here, it's here. And then I guess I'm gonna make it up for you. Yeah.
So like at the end of the yours down, the next slide of the act, the next slide of the start. Yeah, wait, the first one. Yeah.
Hello, everyone. We're going to get started again. And I don't think you'll want to miss this one after the last session. We're talking about insurance. Thank you. Hello. We're about to get started with our next session. I'm Kate Stover. I'm the National Director of Digital and Content Marketing for the Myasthenia Gravis Foundation of America. So it's nice to meet so many of you here today. I'm introducing our next panel discussion. Joining us today to talk about insurance coverage are Michelle Vogel, who is a patient advocate, Jason Gittleson, Vice President of U.S. Market Access for Alexion Pharmaceuticals, and Joey Robinson, who's a field reimbursement manager also with Alexion. Joey is here today speaking in place of Jessica Grieg, who was unable to make it, although she's in the program, she was unable to make it at the last minute. Michelle has been a patient advocate in the specialty pharmacy space for many years now. She's dedicated to helping patients navigate the difficult journey of insurance coverage and denials, and advocates on her patients' behalf to get them the treatments that their neurologists have prescribed. Michelle currently works for IV Solutions RX, a specialty infusion pharmacy. Jason Gittleson and Joey Robinson are here to provide insight from Alexion, which, as you probably know, is a global pharmaceutical company focused on developing life-changing therapies for people living with rare disorders. Jason is committed to ensuring patients have access to medications, and Joey supports neurology patients, helping them with reimbursement issues. Thank you all for being here today. We're excited to hear what you have to say.
All right, good morning. I think we can get started. Thank you for that introduction. Thanks to all of you today. As was said, my name is Jason Gittleson. I lead the U.S. market access team at Alexion. We work with insurance companies. We work with specialty pharmacies, specialty distributors to make sure patients have access to our medicines. And Joey Robinson, maybe just a quick introduction about the FRM role.
Hi, good morning, Joey Robinson. So as a field reimbursement manager, I work directly with offices and infusion centers to help navigate prior authorization requirements and appeals that may come back from insurance on products.
Thanks, Joey. Okay, we have a couple topics. Joey and I are going to start with talking about navigating the insurance process. Michelle's going to talk a bit more about how you can find support for medicines and the cost of medicines. I am going to start, I would say, with the 30,000-foot view. I want to talk a little bit about healthcare is paid for in the United States. I hope to give you a better understanding of your critical role in financing healthcare in the U.S. and why you do have a right to speak up about how important it is to have access to the medicines once you and your physician decide that you have an appropriate choice. While Joey and I are both Alexion employees, our views today are our own, given our time in managed care, which is quite a bit of a long time, and do not necessarily represent those of Alexion. So again, starting with the 1,000-foot view, 30,000-foot view, and this is truly the high view. Let's think about all the goods, all the services that are produced and sold in the United States. That's the gross domestic product in 2021. That was about $23 trillion. That's a lot of output that we have in the United States. Of that $23 trillion, about 4.4 trillion is spent on healthcare. Now that spending on healthcare is split about 50-50. You can think about that as kind of private pay. Those are our employers. That's what we spend, and then government pay. But let's think about that a little bit. Programs like Medicare, for example, yes, it is government pay. But that revenue that the government uses for spending for all of us, most of that does come from tax dollars, our tax dollars, the tax dollars from the organizations that we work for. I think in many ways, we are just critical financiers of healthcare within the United States. So again, about 18% we invest in the healthcare for U.S. citizens of the GDP. Well, let's think about how that money is spent, and that's the next chart. About half of what we spend on healthcare is in hospital services. It's in the services we receive from our physicians if we're in clinic. You can see the number on the slide says about 9% for retail prescription drugs, but that's not really total drug cost. We know that not all drugs are delivered through retail pharmacies. What the actual number is a bit of a difficult estimate. It's not always easy to understand what is the price actually paid for medicines when you consider the price concessions that go to different payers. So I saw two estimates. One was from another government agency that said that number is maybe closer to 18%. So well behind what we spend on hospital and physician services, but more than 9%. And then I saw one that was kind of in the middle, right about 13% of what we spend on healthcare in the United States is on prescription medicines. So again, overall, we invest about 18% in prescription on healthcare in the United States. And then if you think about, well, what percent of that is on prescription medicines, maybe that's 13, 15%, and that's all medicines. When we think about those living with rare diseases, it's a significantly smaller portion of that we invest for medication for healthcare. So that is the top line. I heard there was a great session yesterday around insurance, and I'm sorry I missed it. There were some really great details around Medicare, the different types of Medicare. And I think, a takeaway from this slide is going to be coverage varies in the United States. We have a mixed system. It can, even if you're on Medicaid, it can vary significantly by state. Within a state, there could be many different Medicaid plans. But again, going back to that theme of paying for our health care, about half of us are generally covered by our employers. Now that's a national number. There's another maybe 20% or so that are covered by Medicaid. About, I think, 15% we're saying have Medicare. Unfortunately, still about 9% of Americans are uninsured. So that's your coverage, right? That's your insurance for your health care. But even with our insurance, we know there's significant out-of-pocket cost. And I think, again, that was discussed yesterday. You pay a premium, you have a deductible, you have a copay or co-insurance for your medication. And if you're insured by your employer and you have a family plan, chances are that total premium is right around $22,000 a year. It's significant. Your share of the premium is maybe around $6,000 and the employer's is $16,000. But again, it feels like, well, employer paid, but it comes out of the same pot that's used to pay salaries, that's used to finance the business. It's a significant amount of our investment as a society in our healthcare. Now, even with that premium, we know, and I'm sure many of you have experienced, there's a deductible. And on average, I think about 40% have a deductible of $2,000 or more. So you have to meet your deductible before your insurance kicks in. Fortunately, in most cases, will have an out-of-pocket max. So while we have significant cost sharing, we will have a max spending each year that can range significantly. The average I saw for employer insurance was about $4,200. If you have an exchange plan, it could be higher. In many cases, that can be significantly lower. But again, the point being that regardless of your insurance, you share a significant portion of your out-of-pocket cost, and those costs are increasing. I know I don't need to tell you that. So you have your insurance and you're paying your premium, and then you get this life-changing diagnosis. And unfortunately, that doesn't necessarily mean, as we heard just now, that you're going to get immediate connection to the medicine that your physician, or have immediate access to the medicine that you and your physician have decided is right for you after this multi-year journey that finally brought you your diagnosis. There are several barriers, potential barriers to access. Not all of them are necessarily bad. A prior authorization, I think, makes sense. You know, they want to make sure you have the diagnosis that the medicine is being treated off-label. These are things that they look for. There could be prior authorization criteria that's less appropriate. It could ask for tests. It can ask for certain things, genetic tests that maybe aren't necessary to confirm a diagnosis. It can become onerous, but a PA criteria is standard. Now, what becomes a bit more troubling from my perspective is the concept of step therapy. And this is the idea that you need to try certain medicines before moving on to the medicine that you and physician believe are most appropriate. And in many cases, we'll hear this require trial and failure. And in certain conditions, you know, blood pressure, cholesterol, perhaps failure is not catastrophic. It's a measure. It's a blood test. You can see you're not responding. What does it mean to try and fail medicine when you have myasthenia gravis? What does it mean to be in a situation where you're getting progressively worse? I see this as a situation where one size doesn't fit all, and what may be a little less problematic nationally can be very severe issue for people living with rare disease. I talk a little bit about something called a copay accumulator. It's just something you should be aware of if you're not already. If you are paying for your prescription medicine, you may be getting copay support from the manufacturer. There are programs in place that take that support and basically subtract it from your deductible. In some cases, you know, that may not be clear to you, where you may feel you've met your deductible, and certainly you get a pretty large bill for maybe a completely unrelated medical service that was unexpected. So we just have to understand where there's accumulators in place. What I thought in my experience was basically the greatest barrier for patients, and that's the formulary exclusion. This is where a insurance company just won't pay for a medicine. It's excluded from formulary without going through a real significant medical exception process. This has evolved quite a bit in my experience. These aren't just maybe traditional medicines where there's many options. There are oncology medicines that are on formulary exclusion lists. There are rare disease medicines that are on formulary exclusion lists. Not all of them have a comparable therapeutic option. But then I learned there's something even more recent, and this is something that I've noticed in the past year or so. And what we call it are benefit exclusions, lasering at the employer level. And this is a practice we're being seen by organizations calling themselves alternative funding vendors. And what these companies do is they seek out employers. It can frequently be those with maybe more of a blue collar population. They bring them a value proposition of reducing the cost of their spending on medicines for specialty diseases or specialty conditions, rare disease conditions. And those employers will basically carve out management of the benefit for these specialty medicines to this alternative funding vendor. In many cases, the employers will then exclude it from coverage on the employers within the employer's benefit design. And then the alternative funding vendor works to put those patients into some type of patient assistance program. Maybe it's with the manufacturer, maybe it's with another organization. And then they earn, I suppose, it's their revenue model, some percentage of the list cost of that drug. I think that's incredibly problematic. I think that relying on a foundation to provide your medicine rather than your insurer, your employer, puts you at significant risk. Now, fortunately today, there's a small percent, about 8% or so that we've seen through a survey of employers with this practice. But what's really concerning is about a third are considering it. And it's known to be something that we're beginning to see. So I would encourage you to be on the lookout for this. And certainly, this is something that I see as even more onerous and dangerous than even some of the challenges navigating the insurance process. So it was a 30,000-foot view, but there was quite a bit I shared. I'll just say one more quick thing. I'm going to turn it over to Joey. Joey's going to talk a bit about some of prior authorization criteria, some of the tools and resources that are made available for people living with rare diseases before Michelle gives even greater detail about different programs that can help.
Hello, how are you guys? Yeah, thanks, Jason. So if I asked for a show of participation of hands around prior authorizations, who's had to deal with one, I bet we'd have 100% participation in the room, right? Everyone is familiar with this term. So what I'm going to help guide you on is a little bit behind the why we have prior auths and those barriers to access. So realistically, when a prior authorization is designed by a payer, when they're designing their medical coverage plans, they're looking at the criteria for the drug, usually as it was studied, to understand who would be included for use of this drug, right, in their plan. So they set a criteria for use around typically matching what the drug's benefit design was, or should be the drug's study design was. So that's kind of give you the idea. As we work through this list, I'll kind of relate back to that. So the first piece here is confirming the diagnosis to indication. When the drug is approved by the FDA, it has a label for use around who's an appropriate patient population, right? And so the first thing they're looking for is the patient being submitted for this drug match the criteria for use, match the label for use, right? Is it an appropriate patient type? That's usually typically one. The next piece is who's referring the patient, right? If we have a patient being referred from myasthenia gravis, obviously you'd want someone who is referred by a specialist in that area, right? A neurologist. If it came from a dermatologist, maybe some questions why this person's referring it, right? We want someone who has a knowledgeable background of the disease states presenting the patient to the plan. Baseline health criteria. This goes back to the study design for the drugs that are being approved, right? We go into study a product. There are certain levels of patients of disease states that are looked at in the design to make sure there's a benefit to that patient. And so similarly, they want to see a certain baseline of health progression of the disease state to know this patient qualifies or at that range where they need a certain level of therapy, right? So whether it's a myasthenia gravis score or an ADL score, activity daily living score, to justify use for the product. Next, looking at prior use of traditional therapies. We know that a lot of times there are older therapies that are utilized that may not be as effective, but still have some use and some efficacy. And so there is a requirement to begin these therapies first, to see, have you tried and used, and we spoke about this earlier, Jason, that around trying use of therapies. A lot of times our insurance plans want to see at least 1 year of use of some of these older products to make sure that they're not going to work before moving on to possibly a more costly product. So going through that piece of it. Site of care requirements. So what is this? Over the course of time, a lot of our insurance plans have looked and said that some places of care may be more costly or seen as more costly to the plan to utilize. So they're looking for cost savings areas of use. Typically examples of this as the hospital setting, the HOPD setting has been seen as more expensive for a lot of the plans. And so they want to use patients who want patients to go to a more costly area, which may be like a home infusion setting. So these are all things you may see as requirements. Reauthorization. So this is going to be going back really to that baseline health criteria and really examining this. The patient has been on medication for 6 months, for 12 months. How are they doing? And importantly, how do we know they're doing well? Being able to go back to that baseline criteria and say, okay, patient was at a 3B, now they're down to a 2A, right? Some means of showing progress of the product to continue warrant utilizing the product along that time. So next, going into what resources are available to patients, standard resources. One that Jason just spoke about, the copay assistance program, right? That's a program most manufacturers provide, which have a set dollar amount for a product to use over the course of the year to help alleviate some of the patient's cost burden throughout the year, and dealing with some of those out-of-pocket costs. Traditionally, in years past, that copay program could help go towards deductibles. We have seen in recent years, plans have begun implementing strategies that mitigate that really and reverse that. And so looking at accumulator programs, right, where the patient, you can utilize a copay program, but it doesn't count towards the deductible itself, or a copay maximizer program. A maximizer takes the cost of the copay, the manufacturer copay assistance and divides it equally for a year. So if there's a $12,000 benefit from the manufacturer plan, they'll take $1,000 per month and apply it equally each month instead of upfront to help with the deductible cost. Patient assistance programs. These are often programs that may provide a free drug for a patient in the instance the patient doesn't have insurance. Or maybe they've transitioned on from care, no longer have employer-based insurance, and they're moving on to a government function in insurance. So being able to provide an intermittent step there for patients who are in that gap. Insurance coverage education. I think this is one of the most important pieces is as we begin to get insurance, we often, if we're healthy and well, we don't think about the coverage being provided to us, right? We just select the plan that looks the best. We don't dig into to understand what that coverage looks like. And so as a patient being able to look and say, hey, I'm on this product, is it covered? And if not, pivoting to a plan that is, and being able to look at that whenever open enrollment comes up to have one that actually benefits you. Also in and out of network, that is the description of whether or not a position you see or a treatment center you see is covered and considered in-network for your plan. An in-network provider is one that's contracted with the insurance company and typically has a lower cost to you and to the plan. And so they're looking for you to utilize places that are in-network versus out-of-network, which have a higher cost associated to everyone. Additionally, education, this is where we are right now, right? Being able to provide patients with resources to educate themselves and learn more about the disease states and the resources available to them to help them through their progress. Performance products coverage information. So a lot of manufacturers will have various websites dedicated to the reimbursement piece, which is what my world specifies on. So basically being able to provide resources to both the patient and to the plan, to the providers for education, right? Whether that's letters of medical necessity, exception forms, how to deal with an appeal. When an appeal comes in, how to read that appeal, understand what it's asking for so that we can answer the questions directly back to manufacturers and hopefully get approvals. I think this is probably one of the best pieces is the importance of as the patient itself, right? We know that a lot of offices are burdened with a ton of responsibility throughout the day, and focusing on one patient, especially with a rare disease, can be time consuming. The patient advocacy role is so important in getting an approval. And I don't think patients often realize this, the ability you have to call your insurance plan directly with your information, with your health records and say, hey, I meet this criteria. I'm going to be honest with you. I deal with hundreds of offices a year around forms around submissions of prior authorizations. It's not always perfect. A lot of times there's sending an entire chart to a insurance plan for approval. The approver on the end of insurance is not going to look at 130 pages of a patient charts, right? They want specifically to know when a patient had an event, what was done about it, the dates, how long it was what was the reaction for it, right? As a patient, keeping your own notes around what you've been on your tried and failed therapies, it's so beneficial to be able to provide that piece of it. Most manufacturers have different patient services programs and case managers as well as hospitals to help you guide this program. It's just important for you to reach out on your end and have more benefits. So I think that's all mine.
Hi, my name is Michelle Vogel. I'm Vice President of Patient Advocacy at IV Solutions RX. We're a specialty pharmacy home infusion company, and I'm going to continue on with assistance programs. So let me start with IVIG. With IVIG, what I've learned over these last few years, a number of manufacturers have started offering programs for patients on certain brands that are for all patients, not just FDA approved indications. So I've listed the certain brands that MG patients can get these products. It's only for commercial insurance, Medicare, Medicaid, any government plans cannot get these programs. But what I've listed, you have Vivigam, Gamaplex, Octagam, Panzica. Those are all IVIG products. I know Dr. Rosario mentioned Hizentra as a sub-Q product. There's also a product called Cutiquid, and that has a copay assistance program as well. So I've listed the amounts that are there that patients can get assistance for there. Also, what I'm happy to say is all of the foundations are right now open for MG. So my first month in my new job, I looked at all the patients and looked to see what assistance we can get for the patients. I found $200,000 in assistance for patients that they weren't getting, either through manufacturers or through foundations that patients would have been paying out of pocket. And so this is where you really can get the help that you need. And that's why I want to talk to you, because the last thing I want to hear from a patient is, I can't afford this therapy, because there are places to go to get the help. So you've got PAN Foundation, which is for Medicare only patients, NORD, and you can get help through specialty pharmacies and home infusion companies. So I'm going to go into all these foundations and what their requirements are in a little bit. So for immune globulin therapy, how do you get the insurance to approve this? And I get this question all the time, I'm not getting approved. Well, number one, you can get it for acute exacerbation, or you can get it for refractory MG. And for refractory MG, you have to try and fail. So when we talked about step therapy applies here as well. So you have to go through 2 or more standard therapies, which I have there. And a neurologist must prescribe the therapy, as was discussed from Jason. Who should submit this to insurance? If you're getting it at an infusion center, it's your neurologist. If it's a specialty pharmacy, or the home. And all patients will require a prior authorization. For subcutaneous IG, we're seeing a new trend where that sub-Q and IV are equivalent. So many companies will accept it. And so you don't have to go through submitting journal articles. Some of them do require it, and your specialty pharmacy will submit it. Before, we had to jump through hoops where you had to be, venous access problems, have headaches, all those types of things to get sub-Q. Now we're seeing more patients be able to just go right on to sub-Q if they're going to get immune globulin therapy. For Solaris and Ultimaris assistance programs, you've got Alexian's one source for Solaris and Ultimaris. And you also have the assistance fund, the PAN Foundation, NORD. So you've got a lot of assistance out there for you if you need it. For Vigarde, you have Argenx program, and you also have the assistance fund, PAN Foundation, and NORD. So for the assistance fund, the criteria, you have to be a U.S. citizen or permanent resident, prescribe an FDA-approved treatment, and meet financial eligibility criteria based upon household income and size. And I've listed all the medications that they cover, which is a list. You'll see that the immune globulin therapies aren't on there. It's just FDA-approved therapies. For NORD, they have 2 programs. So if you don't have insurance, they actually have a program that will help you with medical appointments. So you can get there. They won't cover the drugs in that program, but they'll help you with a lot of other things. So that's really someplace to go. But if you have insurance and you need assistance, they cover your premiums, deductibles, co-pays, co-insurance costs. They'll help with medical appointments, medications, labs, diagnostics, physical occupation, speech therapy. So their list is really extensive. You have to be U.S. citizen or resident and fall within the program's financial guides of 400% of poverty level. If you're above that, but you have debt, they'll apply that to bring your level down. So you should still consider applying for it. the PAN Foundation. So for this, their assistance amount, which they publicize, is $9,100. And then if you use up that amount, you can reapply if the fund is still open for another $9,100. So that's really great. And then they have another $500 if you need it for transportation per year. The eligibility, you have to reside and receive treatment in the US or US territories. You have to have Medicare. They don't allow just any other insurance, Medicare, and have an income that falls at or below 400% of federal poverty level. Again, they'll accept if you have certain medical debt to apply towards that. And the medications are pretty extensive. So it's not just the FDA approved medications. So you'll see immunoglobulin included in that list. Now, this is another group, Conquer MG. It's just for patients who live in Illinois, Indiana, or Wisconsin, where you can apply for $1,000 per year, and you can use that for medical treatment, durable medical equipment, medication, and it's, you apply if you have any hardships. So that's a good fund to look at if you're in those states. And this one is a really great one that I don't think people look at to apply for, Medicare Extra Help. So if you are on Medicare Part D and your income, if you're single and it's you have to have $16,660, or if you're married, $33,240. If you don't meet that criteria, but you're close, you could still apply and get partial coverage. This will wipe out a lot of your costs within that Part D so that you don't have that donut hole. And it'll cover most of the costs for the drugs. So it's worth looking at and applying. I've looked at this for patients, and patients who barely could afford their drugs, now they're covered, their spouses are covered. So it's a great program to look at and apply for. So really important, enrolling in manufacturer programs can help you navigate the complex healthcare system. Funding assistance may also be available through third parties like foundations. Advocating for access with the supportive organizations like MGFA can result in overturn of treatment denials. I wanted to share my contact information. I love navigating health insurance. If you need any help, you can ask me. You don't have to be a client of IV Solutions for me to help you. I'm here to do anything that I can to make sure that you're taken care of. Any questions?
Can you show that last slide?
Thank you. Sorry, I'm towards the back. You alluded it, but many medications say for commercial only. And, if you're on Medicare or some other government, I know you said there's, that Medicare assistance. I thought they had changed the law last year to make it, more friendly, more funds available. What do you do if the assistance program for prescription says, it's not for Medicare? Is there anything to do with that, or is there any alternatives?
So depending on the medication, you can either apply. So PAN Foundation covers all medications, so that's a great place to go. Depending on where you're getting your medication, if you need assistance, you can also, if you're getting it through a home infusion company, most of them have hardship programs. You can apply there for help. The other thing that you're alluding to is that what they're going to do is start capping the amount of money that you're paying out of pocket to $4,000. And that's going to be in a few years. So that doesn't go into effect yet with the donut hole. So that's going to change. That's still a nice chunk of money. So this is where you have these other programs that come into play to help, or NORD that you can go to that will help with all the drugs.
I just have a comment. I'm the National Director of Patient Advocacy for Solio Health, another specialty pharmacy. And I wanted to speak to the copay accumulators because that has affected my life as well. I'm on IG and my son is on IG for primary immune deficiency. So this hit us really hard this year because with the copay accumulators, what you do is you only have so much that the manufacturer will give you. So we're on Hizentra, just to give you an example, they give you $5,000 a year. So that's as much as you get. Once they pay you that, they don't give you any more. So if it doesn't go towards your deductible or out of pocket, then you have to actually pay that, correct? So there's a workaround and I wanted to help you. So what we did is I called the manufacturer and I said, now, if I pay that out of pocket, now I know that may be hard for some people, but I said, if I pay that out of pocket, will you reimburse me? And they said, yes. So that's a way to work around it, is you pay it out of pocket first, and then they reimburse you. That meets your deductible and possibly you're out of pocket, and you do that until that's met. And that's the workaround of how to do it. And it's a really big help for these copay accumulators. So I just wanted to give you that.
All right, there's no more questions. Thank you all very much for your time today. Yes. We have a break until, I believe, 11 o'clock. Is that right, Dova? Yes.
So that, oh, now it's working.
We didn't say anything else.
Okay. Good morning. Good morning. Hi, everybody. Good morning, sunshine. That's my usual. Thank you so much for joining us. This is a really special part of our day and a special part of what we do at the MGFA to inform and advance research. And we have a really wonderful tool and asset to the MG community called the patient registry. It's really about your lived experience and real world data. We hope that your participation in the registry will increase. I think understanding and learning more about the registry is truly important. A lot of patients don't always connect themselves to research. However, you are powerful partners in research. And when data is collected in a way that that researchers can aggregate what they need to formulate new and better treatments, you make a significant contribution to helping that. That is the aim for drug discovery. And we really appreciate your participation. Those of you who were in the registry previously and you're not necessarily active right now, we're going to learn a little bit more about the registry today. And we certainly hope that you will join us again. So the MGFA relaunched the registry very recently, within the last year. And we have a new partner called Alira Health. They are experts in this space, and we are working a lot with drug development partners to help us find better and effective therapies. So today we have a guest who will join us, Renee Willman, who works with Alira Health, and she is the Senior Director of Real World Solutions. And I'd like to ask Renee to join us. Please help me welcome Renee.
Thank you so much, Wendy, for the warm introduction to me and to the registry. I'd like to start by thanking everyone in the room for making their way to New Orleans and for staying until the end of the conference. I know it's been a very action-packed few days. I have learned a lot, and it's been such a pleasure to get to meet many of you and really hear firsthand your experience with MG. I also want to thank the MGFA for inviting me to come today to talk about the registry, to have the opportunity to meet so many of you, and for really folding me into the team. At Alira Health, we really value the relationship with patient advocacy groups and by extension, the patient communities that they support. And having had the opportunity to work with many patient advocacy groups in a variety of different disease states, I can very confidently and honestly tell you that MGFA is a treasure. They are a very sophisticated and well-organized group. The fact that you've had this registry for many years and that you have such intentional, thoughtful, and personal relationships with a variety of sponsors is not super common, even in the rare disease space. So I know I'm preaching to the choir on that front, but the MGFA has really been wonderful, and I appreciate all of you participating in the variety of programs that they have. So what I want to talk about with you today, and I hope that this is really the beginning of an ongoing conversation, is about the patient registry, what it is, how it's changed, because as I said, and as many of you know, because you've participated in the past, MGFA has had a patient registry for many years. Why everyone should consider participating, not only giving their data once, but continually investing the time in updating the registry and how you can best participate. I'll also explain to you what happens with the data and what is happening behind the scenes in terms of our partnership with the MGFA, our relationship with sponsors, with academic researchers, and with the medical community, so that you have a better understanding of how you can contribute to all of the movement and development that's happening in this space. And then hopefully we'll have some time for questions. And I welcome any of you to reach out to me directly, to our team, through Wendy, if you have ideas or questions about the registry. So first, it's important to understand what is a registry. And there are a couple of different types of registries. So it's even a question or a definition that's not always very clear, even amongst researchers or industry, because a registry is really a repository of information. And when it's a patient registry, that means that as patients, you contribute your data directly. And there are other registries where physicians would give that data. It can also be simply, databases of a collection of various information. So in this case, the fact that the patient registry has been in place for so long is significant, because in the drug development space, the regulatory environment that approves new treatments, the FDA, there's been a lot of interest in the last couple of years in patient registries and in how we can incorporate what's called patient experience data and the patient voice in medical decision-making and the drug discovery and approval process. So just like, our state of understanding of MG languished for many years, and in the last 30 years or so has exploded, the value of patients' participation, of you sharing your stories, of making sure that you are empowered to be active partners in this process has become a very urgent priority in the last couple of years, more so than it has been in the past. And so the evolution of the registry has been part of the MGFA's efforts to really stay abreast of that new change in the way drug development is happening, and making sure that as patients, your voice is counted in these new opportunities. So before I go on to talk about the registry, the MGFA patient registry, the founder of the company that I work for, Self-Care Catalysts, which was then acquired by Alira Health, but really the company behind the new digital platform that hosts the registry, used to always say, no one trains you to be a patient. And yet we all become patients at some point in our lives. Obviously not to the same extent, but being a patient today is hard work. There's a lot that you have to do to educate yourself, to stay abreast of your own symptoms, to understand what's going on, and to advocate for yourself with the medical community. You are the single node of a very complex system that is going to interact with almost all of those other nodes in some way, shape, or form. So your role in how, physicians, insurance providers, drug developers, patient advocates, nurses, specialty pharmacies, all of these players have very important roles to play, but the commonality between all of them is you. And so never underestimate the power of your experience and of your data. And that is really the central purpose of the registry, is to be able to empower you to contribute the uniqueness and the value of your personal experience into a collective repository, so that we can amplify those voices and start to make sense of patterns that are currently not very well understood. So the patient registry, and specifically the MGFA patient registry, is a collection of information about a group of patients who share a condition or experience. And it really represents an important way for you to contribute your experience, your perspective, and your ideas, frankly, about your disease with the medical community. And that helps to achieve improvement in care, treatment, and research. And so, as I mentioned, critical agencies like the FDA are prioritizing the direct involvement of patients, and so that you can donate your data to this process. And registries are a way to include a wider variety of people who may otherwise not be able to engage in something like a clinical trial or some of the more formal research endeavors that you may be more familiar with. So in terms of what's changed about the MGFA registry and the partnership with Alira Health is that there really was a very intentional process to identify greater functionality so that the registry serves you in multiple ways. We don't want it to feel like, homework for you to have to fill out a questionnaire, but something that you can interact with on a regular basis where you're sharing your experience and you're gaining that personal insight and value out of doing that. As Sam mentioned in her opening remarks for the conference, we also have global capabilities through the new Health Storylines platform. So that means that over time, more and more patients in different countries, in different languages are going to be able to contribute their information to the registry as well. So that collaboration with other MG communities across the world can all come together. Interoperability is another important new development where the ability to integrate wearable devices, bring in your own medical record data, and really be that, single place where all of your health information from maybe 6 different neurologists that you've seen and your family doctor are all in one place where you can bring that confidently to get a second opinion. Or if you end up in an ER while you're on vacation, you have all the information at your fingertips that you may need to get the care that's required. In terms of our partnership, Alira Health has experience working with sponsors, with patient advocates, and directly with patients across the entire spectrum of the life cycle of drug development and product development. And what that means is that we can really make sure that the right stakeholders are getting access to the right information through the registry, and that the questions that are included in the registry are getting the kinds of information that those stakeholders need to make decisions that are in your best interest. That also means that this repository of data can be used to advance treatment and even advocacy with insurance payers or other decision makers that influence the treatments that you can receive in ways that you can help to direct. So your opinions, the information about how you go about your treatment decisions, the conversations you have with your physician, all of those are going to help us inform this ecosystem that you're a part of. And so those stakeholders that are listed on the bottom of the slide are really important to the MGFA, and they have been involved in the entire process of identifying us as the new partner for the registry and in any changes that are going forward. So patients, your healthcare providers, industry sponsors, academic researchers, and obviously the MGFA and their strategic goals as well. So why participate? This is very important. So I'm going to spend a little bit of time on this slide. The registry offers a way for patients to share your experience with MG and the impact the disease has had on your quality of life to contribute to improvements in care and the discovery of new treatments. And when you look at that picture of an iceberg, that top small part is what we know about MG and what we know about the healthcare, about how you live with MG based on the data that's available in the healthcare ecosystem. Through clinical trials, through the analysis of medical record data, through the analysis of insurance claims data, what you'll hear referred to as real world evidence. These are bits of information that as systems become digital, there are these existing repositories of information that researchers try and use to figure out how are patients diagnosed? What are the sequence of treatments that they may be prescribed? Are doctors prescribing treatments in the way that the insurance companies want them to, or that the current treatment guidelines recommend? And yet, all of the other pieces about your real life, about how your ability to manage your energy impacts your relationships, impacts your ability to maintain a job you love, or to travel with your friends, to work with other people, to the friendships that you form, where you may choose to live, your ability to use public transit, all of these things that to a healthy, able-bodied person may seem completely not important, it may never cross their mind. These are all extremely important elements of your lives that you know intimately, and that one of the best parts of coming to events like this is that you get to be with your people who get it. And obviously the people around on the edges of the room who are developing treatments, especially in rare disease, they try very hard to connect with you as individuals to learn about what that process is so that they can serve you. But the gap is that those of us who are maybe shy, who may not feel comfortable participating in a clinical trial, who live far away from someone who's an expert in MG, or who can't travel to participate in a trial, their experiences are lost the most of the time. And we don't want to lose them. And so by participating in the registry, what we want is to improve that representation, is to really get that story, the understanding of what's going on in your life and how MG is impacting you, regardless of where you live and what challenges you may face. So some of the specific things we might want to increase in terms of representation are diversity. The participants in clinical trials in America in general, across all conditions, are too focused currently on a particular patient population, which tend to be those who live in major cities, who have access to really top-notch care, who are often those researchers who are doing the trials, and have the financial means to be able to take time off work to go to a clinical trial and to participate in a study. And so rural populations, minority communities, African Americans, other immigrant populations are systematically not included, and yet they need these treatments just as much as everyone else. And so by participating in the registry, it may feel like something very straightforward, like filling out a questionnaire, but by participating year over year, continuing to update that questionnaire, even if your answers are exactly the same as the year before, you're giving very important information about the stability of what it means to live with MG. Is your experience changing? Is there a seasonal element to it? Are there other comorbidities you have that have made it difficult for you to participate in a clinical trial? Are there other things like your age or where you live that have prevented you from actively participating in research like a trial? These things don't preclude you from participating in the registry. If you have a computer or a phone and can answer these questionnaires by yourself or with someone else's help, then you can participate. And by participating, you help represent people like yourself in what we know about MG. And especially for people who are newly diagnosed, these insights and even the process of entering that information will help you reflect on what is going on with you. And in yesterday's talk, we heard a lot about how that process is empowering, of having that self-knowledge of what is happening with your treatment. Are you responding to the medication to the extent that your doctor wants you to? You can now inform and educate your care team, not only with the conversation that you have in that room, but by showing them a form of data that they tend to understand. The doctors, your care team, they all understand the scientific process. They spend many years in medical training. And so seeing data really helps them have those light bulb moments and have a conversation with you where, they care about you as a person, as a patient very much already, but being able to now also have a conversation in terms of number of days you had symptoms or severity on a scale from 1 to 10. Some of these new ways that the registry will equip you to describe your experience will help you educate your care team about what's going on in your experience. And by participating, you'll also be able to receive updates about new research opportunities that you can participate in, that you may be eligible for based on the criteria of the trial and whether that matches your patient characteristics. And connect with the community in between meetings like this by seeing how your experience compares to others based on the results that we will be sharing. And so I don't expect you to be able to read this slide. I know it's very busy, but this is a very high-level overview of the clinical drug development and research process, starting with discovery of what molecules may work. We learned this morning about some of the different pathways that are impacted using different treatments. And once we start actually testing these medications in patients, it's not only a very long process, but when you think about the numbers of patients that are recruited into these clinical trials, the amount of work that goes into opening a site, making sure that you can provide the right molecule to find the right dose to inform new treatments, there are a lot of moving parts. And the companies that are working on this research are focused on all of the specific variables that relate to their particular molecule or their particular pathway that molecule is going to target. And so a registry is a great way to sit on top of and across this entire spectrum and be able to inform which patients can we reach out to recruit for this study. How are these patients different from others who are not currently well served by the treatments that are on market? How can we identify some of those other patient populations that need to have more research conducted and then empower those people with data? And so beyond the individual level of participating and learning more about yourself by completing the questionnaire and potentially using the Health Storylines app, which is now available to monitor things like symptoms, the community benefits of participating in a registry are tremendous. Not only with MG, but the rest of the rare disease community benefits when we have strong registries. The ability to compare data between registries helps a lot, especially when you know that there are potentially common underlying biological mechanisms that we just don't know enough yet, where if we can compare the data from the MG community with data from another rare disease that may be on a spectrum or commonly comorbid with MG, we can learn so much more. And this empowers the research community to interact with that data, develop new ideas, and then continue that cycle of research. And then, of course, industry who are working on drug and medical devices, whether that's for better and faster diagnosis, for treatments, all of these different opportunities are currently one person around this elephant of MG, of trying to figure out the part of it that is closest to the specific work they're doing. And a registry has that capability to bring all of these together and understand what is, the nature of this creature that we're really dealing with, and connecting insights from two ends of what may seem like completely different animals that are actually the same. And one of the benefits of the new registry format is that it leverages the power of storytelling. You can go in and use tools like a journal tool, like symptom tracking tools, to document your own MG story in your own words, in addition to through a questionnaire that's much more straightforward to analyze statistically. That allows you to share insights with the community. And when we start to see patterns of common experiences between people, you may not have to wait until the next meeting to talk with someone who has MG and learn that, like, I had a similar thing go on, and actually I talked to my doctor and they recommended this. You should try that. We'll be able to show in reports that a certain percentage of MG patients have had success with certain treatments, or found a really effective way to engage their physician in moving them from one treatment to a next one, was by sharing this particular type of data, and really accelerate that learning and the sharing of those learnings to really empower everyone to learn from the experience of others. And so now, in terms of the actual how to participate, where you will go to join the registry if you haven't before, and even if you have in the past, then you would go to the mgregistry.org website. And there is a link from the MGFA website. And you have now more options in terms of how you can donate your data. You can sign up on desktop, which will allow you to use your computer. And you can also download on mobile the app called Health Storylines. And I do just want to draw your attention to the Health Storylines logo quickly, because you will go from this MG registry page or the MGFA website that is very familiar in terms of the colors and logos, but it's going to send you to a part of the App Store, and the app is called Health Storylines, and that's not a mistake. You didn't end up in the wrong place, but that is the name of the digital platform that the registry is hosted in. And so once you go through the process of creating a login for Health Storylines, you will then again see the MGFA branding and that you're in the MG registry, and the questionnaires will be there, as well as some other tools. So this will work on any type of smartphone that you have, and you can start the questionnaire on your computer and then later finish filling it out on your smartphone, or vice versa. The questionnaire will save as you go. So if you want to complete it over multiple days, you can. You don't need to sit down and spend a long time answering all of the questions. It's really designed to be flexible and to meet you where you are. So if you find that the questions are too hard to read on your phone and too small, you can feel free to go onto your computer or project it on a big screen and use it there. You can also have a caregiver work with you to fill it out, or you can even reach out through our support email and someone will call you and ask you the questions in person, and you can just tell us the answers and we'll record it for you. So it's really important to us that there are multiple ways for you to engage. And if there are difficulties that you have at any time, we do want to hear about it. So don't ever feel shy to let us know if there's a problem, if there's something you think can be improved. We do have the ability to modify how the app can look or respond because we are able to tailor it for many different conditions. And so we want to make sure that it's perfectly set up for MG. So there are two primary ways that the registry is collecting information. And these images are some screenshots of what the MG app looks like on my phone. So there's the enrollment questionnaire. When you first sign up, you will fill out an enrollment questionnaire. And then twice a year, every 6 months, there is a follow-up. So the follow-up questionnaire is currently open, and then it will be available again in the summer. And the reason that even if you feel your answers haven't changed, it's so important to fill out that follow-up is so that we get what's called longitudinal data. We want to know what's happening over time. Are treatments changing? When you are put on a new treatment, how long does it take to have an effect? Do you have unexpected side effects? Does it impact your mood? All of these things, and how does it impact your quality of life, your ability to, carry out your day-to-day activities is really important so that we can vet, those guidelines in terms of how long a patient would have to stay on a medication before it's appropriate to switch, or whether a dose needs to be adjusted. And in between those 6 months, you can also use the tools within Health Storylines to add information. So there are some that will help you in your day-to-day management if you are someone who takes a lot of medications on a regular basis and would benefit from reminders. The medication tool can be configured to send you pop-up notifications on your phone, and you can track your ability to take your MG medication or other medication regularly. You can also customize the symptom tracker to include the symptoms that matter to you. So depending on what specific symptoms you experience, you'll build that list, and then you can go in and just drag a slider to show how severe they are on a regular basis. And there's also a journal tool where you'll have your choice of prompts to respond and to collect your own thoughts. You can use it to track, your response to the food that you're eating. You can use it to reflect on, a gratitude journal. We've also heard a lot about how your mindset has a huge impact on how MG will affect your quality of life. And so some patients want to use this tool as a place to reflect on what's working so they can go back and see those good days, what worked, what friends have been there through their process. And also if you have ideas about, I'm starting to see a pattern, or maybe there was this thing that happened to me in my childhood that triggered MG because I talked to someone who had a similar story as mine, and that's what they were thinking. And understanding a little bit more about how you're processing and living your life with MG is all going to help the research process. And so you do have this flexibility. Of course, no one's required to use it on a daily basis. It's all completely up to you how you use it in between. But those standardized surveys and having that structure is what's carried over from the former registry, and what's going to allow us that continuation of many years of data of understanding MG. And so what happens to the data is also very important and a common question that we get. And so first and foremost, I want to assure you that the data is very secure and private. Our platform and the same tool is used in many clinical trials to collect data. It's used by other patient advocacy groups as well. We comply with global standards for privacy and data security. So whether that's HIPAA or GDPR, we have a lot of experience and a very competent technical team who make sure that that data is always safe and private. And any analysis is conducted on de-identified data. So none of the insights that you're sharing are going to be attributed directly to you. You're never going to come to a meeting and someone from the MGFA will be like, oh, how are you doing with this? And the only way they could have known is that they read it in your journal. That would never happen because they'll never be able to associate that information with the person who reported it. What will be shared with you, however, is you can always see the information that you've entered into the app. You'll be able to go back and review the questions that you answered. You'll be able to go back and look at your journal. You'll also have graphs and the ability to look at your symptom changes over time so that you can share that with your doctor. The circle of support is a feature where you can add other people to your registry app. And for example, maybe someone in your support group, you've teamed up and shared visibility of your symptom tracker so that you can kind of check in on each other without having to call and ask explicitly. You can just see if they're doing okay, but you can also keep your journals private. So you can choose at the tool level who you want to share your information with, but this is often useful for like caregiver or family relationships where you may live in different states or far apart and want to still be able to be in touch without having to, deliberately ask those questions. And we're also going to be working with the MGFA to create newsletters and reports specifically for the MG community so that we're sharing what we're learning from the community, what questions other people are having, so that you can contextualize your own experience with the rest of the community. And as I mentioned before, really start to accelerate that ability to exchange information and share how you're doing with everybody. And data access by researchers and industry partners is vetted by a committee called the Research Advisory Council that is supported by Alira Health. So the MGFA, of course, is going to be very carefully considering the requests to access data and what those motivations are. So that if industry is wanting to, recruit to a clinical trial or understand the relationship between a certain treatment and quality of life, we will be working as a team to help facilitate those analysis and make sure that the data isn't available to anyone who may have less than helpful intentions to support the community. And behind the scenes, that diverse team of stakeholders who've been involved from the start of this process of evolving the registry are being engaged both through board activities, through the Registry Advisory Council, but also day to day between Alira Health, the MGFA, and the trusted relationships within their network to do things like refresh the questionnaire to make sure that we're asking the right questions, that we have information on all of the latest treatments, on different ways that researchers are using to understand the MG community so that they are excited about accessing the data, and that by providing it, you're also learning about yourself and how you're doing over time. There will be upcoming communications about research opportunities. So sponsors also have the opportunity to collaborate with that group of us to send communications and bring to your awareness studies that you may be eligible to participate in. And if you're interested in learning more, we'll connect you with the right stakeholders so that you can go through that screening process and then any support that they may be able to offer to make it easier for you to participate in clinical research. And we'll also be doing learning sessions about the registry. I've had the pleasure of meeting some of the volunteer leaders at this conference, and we've already started talking about opportunities to present to the support groups about the registry, how they can enroll, how it can help them as they learn to manage their MG. And we want to hear your ideas as well. If you're using the app, if you're inputting data in the registry and you have a frustration or you have an idea for a tool that could be helpful, content that you want to share, please let us know, because this isn't something that's static and fixed. We do want it to be a helpful tool for the community and an extension of the community's ability to really advocate for yourselves so that you're empowered to take this data that you have and bring it to the researchers that you want to consider your information. So for example, Dr. Nowak is part of the organization that is working on this data and helping us move it forward. And to make it as effective as possible, we need as many folks in the MG community to participate and to continue to provide their data in an ongoing basis, because that is going to give us the most valuable and robust data set that all of these researchers can bring their brilliant minds and ideas to advance opportunities for the MG community. So I want to thank you so much again for your time, for listening to me talk about this today, and for participation and engagement in the conference. That is the website to enroll. We also have a bunch of notepads on the registry table that have a QR code for you to sign up. And we would be thrilled if you would all grab one, take it home with you, give it a page to anyone you know with MG so that they can also enroll. And if you need help as you're navigating it or have any questions, you can reach out to our team. Adrian is my colleague who monitors this email and who will be in touch with you. And he is wonderful and he would love nothing more than to help you make the most of this registry app and tool. So thank you so much. And I think we have some time for a few questions if there are any.
Hi there.
Hello.
At the last in-person conference, I asked the question of the gentleman that spoke about the registry that was then. What has the outcome been in reports or development that came as a result of the information given in the registry?
Yeah, so the registry we haven't like chopped it off and started fresh. All of the data that has been provided in the past number of years to UAB, who was formerly managing the registry, has been transferred to the Health Storylines database in the Lyra Health team. So there are some publications and scientific research projects that were conducted over the past couple of years on that data that have been reported in the scientific literature. And we're already working on projects with industry to analyze the data that was passed on from them. So that data is certainly still very valuable and will be part of that longitudinal characteristic of the registry is one of the most important and valuable elements. So that has not been lost. And we're essentially carrying it forward with the addition of new functionalities that will continue to expand what we can do with the registry data set moving forward. And certainly, creating summaries of the publications that have already been written and published that are patient friendly and putting those into the app is something that we would be able to consider and to build out so that the community can also see what learnings have already come from the registry, if that's not something that's already been communicated to the community.
Thank you. Are patients going to have the ability to search the database for symptoms, location, the things that we would be interested in and comparatives? So who else is seeing these kinds of things? It's great for research, but we're always wondering, is anybody else experiencing this?
Of course. Yeah, so initially it's going to be in the form of those reports that are designed specifically for the community that will show, this is the proportion of the community that are experiencing these symptoms. This is the kind of a heat map of geographically where our patients living and any significant associations between symptoms and where you live. So some of those patterns we will be sharing with you. In terms of the direct ability to search the database and do your own research, that is something that we have talked about creating something like a dashboard. So that's not available yet, but those kinds of ideas are exactly what we're discussing with the MGFA registry leadership team and the Research Advisory Council to, as we move forward together, build out those features that make it really valuable for you.
That would be great. And that's the empowerment side of the patient.
Exactly.
I do have a second question if I can. Are you integrating with any of the other registries out there like all of us?
So currently we don't have direct integration in terms of sharing of data. We're certainly open to exploring collaborative relationships and with the research community, that's something that, we can build projects that leverage data from multiple sources. So whether there are other registries in MG and comparing analyses, or even looking at outcomes between MG and other potentially related autoimmune conditions. So there are a variety of ways that those forms of real world evidence that registries are part of that, we can connect it to that broader ecosystem of health data.
Anyone else?
Well, thank you all so much. If you have questions, feel free to come chat with me. Oh, there's one more.
We have one more.
Great.
Kind of a morbid question, but how do you collect deceased information?
That is a very fair and good question. We currently do not in the patient registry, because if the patient is no longer able to report data, we simply see a drop off of the data from that person. So we currently don't know, for those of you who used to participate, what happened or why that cessation of data coming into the registry occurred. So there are a few ways that we can explore how to fill that gap, whether it's having a care partner identified so that they can follow up, potentially being able to connect medical record data in a way that provides a continuation of that data so that we would find out from the medical record when a patient is deceased or no longer able to contribute data. But that is actually a common question that researchers grapple with in these real world data sets. And there are a variety of ways that we try and figure that out in research. But it's something that we are thinking about for the registry as well. Thank you. Great. Thank you so much. I hope everyone has a safe trip home.
Hi, everyone. Me again. How are you guys doing? Ah, I like that. Good. I like that. Wonderful. Okay, well, I really want to sincerely thank Renee for flying in and spending time at the conference. She didn't just come in for the session this morning. She actually came in to see the whole conference and really understand the mission better, certainly, to meet you as community members. And that was really important to her. So if we could just give her another round of applause. Thank you. All right, on to our final session. But first, I just want to say, because I was remiss, I actually didn't come up here this morning, and I should have thanked our partners at Roche for sponsoring the breakfast. And so I just want to thank Roche. They're a new partner to MGFA, and we certainly appreciate them supporting the conference in that capacity. So thank you to those of you who are still here. Yeah, definitely. Okay, so this is the part where I sort of can't stop smiling, because we're on our last session, and it's actually going to be focused on learning a bit more about what MGFA is up to and what we've been doing. I touched on this a little bit the other day, but now I have the extreme pleasure of being able to bring team members up to be able to talk to you guys. And that makes me very happy, because obviously I love the work that we do, but I love the team that I work with. And I don't just mean like, oh, I really like working with them. I mean, I love the people I work with. I feel love and adoration for the people that I work with. I feel very blessed that I do enjoy the type of work that I do each day. This team is very impassioned. It's a team filled with really good people. They're very good at what they do, or they wouldn't be on the team, but they just happen to be a group of really, really fine human beings. And I want you to hear that from me. And we have a lot of fun together, we do. And certainly the work is rewarding, but it's a group that works extremely hard, day in and day out, believes in this mission, believes in our community. And I mean it when I say that it has meant everything to come here and be with you for a few days and to talk to you and rub shoulders with you. So from us to you, thank you for this amazing opportunity. Okay. So I touched lightly, I'm not going to be up here too much longer because this is the last session and we have condensed time. But I touched lightly the other day on the extreme growth that we've had over the last 3 years. And but I didn't really go into any detail other than telling you that the organization has doubled in size, and we've severely increased the amount of research funding that we do. But within all of that, in the last 3 years, we planted some pretty special seeds, and we're cultivating them and taking care of them, and we're watching them grow now. And it's time to really start talking to you guys about those things, because it's not just about your engagement and participation. It's about the benefits that you can get from those things. It's about how you can connect with others. And we know and can see how important that is to all of you. That's just a basic human need to connect with others. So we're going to talk to you about a lot of different things, ranging from our patient programming and how you can participate in those things and benefit from them. We're going to talk to you a little bit about what does strategic development mean, and that could be anything from fundraising to participating in community services. We're also going to talk to you about marketing communications. That's always fun because Mike Antonelli is going to come up here and he has great energy. And then we're going to talk to you a little bit about globalization, a little bit on each topic, but mainly for you to learn more about what the MGFA is up to and how you can benefit and participate. Okay.
All right. Good morning, everybody. Thank you all so much for staying. And this is the last day. It's pretty bittersweet. I just wanted to take the time to say thank you all. Thank you all for showing up. I'm truly blown away by everyone's commitment to being here and the passion that they have for supporting MG patients. So thank you. Just thank you for showing up. It means more to us than you know. And as someone who has myasthenia gravis and my fellow community members, as I said in the program, we don't take these opportunities for granted, right? These in-person and virtual with our virtual attendees, these opportunities for granted, especially being immunocompromised. This time we have together is so valuable. So just wanted to say thank you. I also do not want to miss the chance to thank my colleague who has been so instrumental in making sure that this conference is executed so seamlessly. Everything that has been done today or these last few days have been as a result of Doba's work. So please give a round of applause to Doba. I don't think people realize the hard work that goes into making these conferences what they are. And she does it with such grace and gets things done. And she's so calm, cool, and collected. And just thank God for Doba. I've had this disease for almost 20 years, but I've, only been at the MGFA now for about a month and a half, 2 months. Nevertheless, within those 2 months, we've been working every single day, many nights, and even some weekends to support my fellow community members. And like I said, I haven't been here too long, but what I'd like to share with you is some of the overarching goals that we, our engagement team, have come up with to make sure that this year is going to be productive and effective. So the first pillar of our team is providing information and opportunities to convene and learn in the same space together. Obviously, we have our National Patient Conference, and I'm just blown away. This is my first patient conference, and like I said, I'm just so impressed by everyone's commitment to ensuring that we live our best lives. And I'm really excited for, already getting started to plan our next year's conference, which, do you want to announce something if they haven't heard?
No, you're leaving that to me.
Well, you deserve it.
So some of you may have heard through the grapevine, but we are going to be having our next
the grapevine of Sam,
our next patient conference in Tampa, Florida. So we're very excited. We're very excited to announce it, and it should be around the same time of year. So we'll get you the exact dates. But anyway, that is our next patient conference.
Yay. So in addition to the National Patient Conference, we have our webinar series, and our webinar series, there's 12 of them, 6 of them dedicated to research, 6 of them dedicated to wellness. And the point of the research webinars is to ensure that patients and community members are staying up to date with the relevant research, all the robust research that's currently taking place in the MG community. And even if you don't necessarily qualify for the trials, it's so important to stay educated and up to date on what's happening in our community. And then our wellness series intended to be to make sure that we are managing our MG from a holistic perspective. And of course, that educational piece and convening together, I don't just mean that for MG patients. We at the MGFA want to ensure that we are providing opportunities for all those that are interacting with MG patients every single day. We have our international conference in which healthcare providers and researchers can share and network and share within all the information that and research that they're doing and sharing in that knowledge and expertise. We also have we're looking forward to developing some educational opportunities for our allied health professionals, first responders, want to make sure that our caregivers and allies feel supported as well. So really creating opportunity for everyone and not just people that have MG. Our second tenet of our patient engagement team is to cultivate safe spaces for our community members to learn, connect, and grow with one another. As many of you know, we have many support groups across the country from coast to coast, and we are going to be taking a deep dive into ensuring our support groups are run effectively and efficiently. And by doing that, we can guarantee that our support group leaders are supported and given the right resources to facilitate these meetings. So taking a closer look at our support groups holistically. And of course, we have our regional conferences. We can't forget about those. We have 5 regional conferences this year, 2 of which will be in combination with our community health fairs. Essentially, those regional conferences are exactly how it sounds, right? It's giving patients the opportunity to access local and regional knowledge and being able to tap into some of those local resources, including local doctors and doctors in your area. So we're really excited for that. Which ones exactly are being in combination with the community health fairs?
San Francisco and Houston.
So our San Francisco and Houston regional conference and community health fairs will be combined, and those will be in person. So very exciting new initiative. And then lastly, our third goal is to take a strategic approach to patient centricity by leveraging our alliances and our strategic partnerships. As we've mentioned throughout this conference, we have a new strategic partnership with Patients Rising. And we're also going to be leaning into all of the other partnerships that we have with fellow patient advocacy organizations. So Every Life Foundation, NORD, Global Genes. Why reinvent the wheel if we don't have to, right? Let's lean in together, collaborate, join in with one another. Because let's remember that myasthenia gravis isn't just myasthenia gravis. It's a rare disease, it's a chronic disease, it's a neuromuscular disease, it's an autoimmune disease. And what does that mean? That's actually to our advantage. That means more resources, more advocacy, more education. So we have some really exciting things coming up for our patient programming and educational opportunities. As I mentioned before, it is such an honor to be serving in this capacity, and I look forward to working with each and every one of you to ensuring that patients are seen, patients are heard, and patients are valued. So from the patient engagement team, thank you so much.
Hello again, everyone. We are the marketing and communications team for the MGFA. And we are so honored to every day touch, promote, and support all the amazing work that's being done at the MGFA and all the way through our MG community. I wanted to quickly introduce you to Kate Stober and Nick Patrone. Kate focuses on digital marketing, content marketing, social media as well, and media relations. And Nick focuses on all of our design work, creative work, web design, and also the work that's being done across all of our layouts and a lot of our web-based applications. I'm going to be talking about two quick topics. The first is MG Awareness Month. So as we all know, June is MG Awareness Month. And we know that many people across the MG community have already been working to try to prepare information, to work with their legislators, state and local, to try to get proclamations written out, to make sure that buildings are being lit, and to make sure that general awareness is happening. Our brand and what we try to focus on in terms of the call to action is actually taking action, turning awareness into action and vice versa. So that we're not in a situation where we're sitting back and, trying to have other people work on, getting stuff done and building awareness, but that we're all participating in ways to build awareness for MG. That could be writing articles like op-ed articles, working with local media. It could be creating a sign and putting the sign on your front lawn. Maybe having small focus groups in your town or within your church or business and talking about the challenges that patients face in MG. It's any small little action or even larger action to make sure that we're all driving MG awareness. Maybe getting on social media and sharing content. And we're going to have a campaign called Dare to Share on social media. And there'll also be a fundraising campaign called Dare to Care. And I think Craig's going to talk about that in a minute. So there are so many ways that you can promote awareness. We will be publishing our awareness toolkit like we do every year. That's going to happen next week. We will have a number of awareness activities and suggestions on our website, on our impact page and our awareness page. We'll be asking all of you and everyone across the MG community to submit photos of the awareness work that you're doing so that we can have a wall of awareness on our website. And we're also going to have we're going to conduct and broadcast a kickoff event for the first day of MG Awareness Month. So we're excited about all these activities. We've already been proactively working on this content and getting it ready. And we'll have expert information. We're going to be telling so many more patient stories, especially in video. So a lot of great stuff happening for MG awareness. So all of you should be thinking about what ways are you going to drive awareness this year? And if you have any, questions or suggestions, definitely, come to me, come to the MGFA, and we can talk through these ideas. The second thing is the online community. So we're going to get some pretty big changes in the online community coming up. We're introducing 3 brand new buildings in the first half and into the summertime for the MGFA online community. We will have an urgent care center building. So we'll have emergency and crisis information, all that information from our website and across the online community will be all in one building. It'll be an urgent care center, so you can find that information in one place. We'll also have an international center, and we're really excited about this. We're going to finally be translating a number of documents into several different languages, and we'll build on those languages over time. Again, as we've talked about throughout the week, the MGFA really is a global organization. And as we continue to move in that direction and have more examples of the MGFA being global, we will be translating important MG documentation so that people around the world will be able to even more easily access and read the information that we provide. Then finally, we're going to have a pediatric center. And it'll be a place where all of, pediatric information, but also there are so many questions that parents have about MG, especially when it comes to their children or explaining MG to their children or to their family and friends. And so we'll have those pediatric materials in the pediatric center. So really cool stuff happening in the MG community, in the online community. We're going to have new resources and new information. And we're also going to have some new incentive programs and as well as chat rooms. So really cool stuff going on. Thank you so much for your time. Thanks.
One more good morning, good afternoon. I have the worst task today, and that is to follow Mike Antonellis. Mike is like the sunshine that comes out after a bad thunderstorm. So I haven't really introduced myself to everybody yet. My name is Craig Strenger. I'm Vice President of Operations and Strategic Development. Technically, we are the development department with Tasha and Caroline. And I'm going to let Tasha and Caroline both talk a little bit about what they do best for the organization, because they are out front and they are dealing directly with all of you and others every day. I want to say technically development department, because most people see development as, oh, that's money. And at the MGFA, we've kind of broken down these silos, for lack of a better word, and we're all working together as one organization. And you'll see that when Tasha talks about health fairs or Caroline talks about partners in care, you'd be like, well, wait a minute, that's not money related. No, it's not. It's strategic development. It's strategic partnerships. It's how can we bring this community together with connectivity, with more advantages for industry to come together and meet you and see you and hear you. And we've turned kind of development on its head. Yes, I still monitor the revenue from all sources, and we try to make sure that we're doing the right thing and bringing in enough money to fund research and every program that we do. But when we talk about the new way of thinking here at MGFA, it's one team with one focus, with one mission. So I'm going to let Tasha talk about health fairs and a little bit about Dare to Care. And those are things that we work with global communications on, with our industry partners, with Meredith and her team. And when Caroline talks about partners in care, again, it's a compilation of working throughout the organization to bring it all together. So with further ado, I'll introduce Tasha and let her talk a little bit about health fairs and Dare to Care.
Thank you. My name is Tasha Duncan, and I am the National Director of Strategic Partnerships and Community Engagement. Introduced in 2022, we launched our community health fair program. I have the opportunity to manage an amazing group of volunteers that help host these events all over the country. We hosted our first 5 last year, and they were very successful. These events are free for all of our MG community. It's your opportunity to come and not only reach out and connect with our national partners, but also we are connecting you with local resources that help you guys navigate your MG diagnosis. So if you have one coming to a city near you, we're doing 8 this year, and we hope you'll come out and visit us. This is also an opportunity for you guys to connect with each other as a community. We have the last, say, 30 minutes of these events are going to be called a community connection. And you'll have the opportunity to just sit and share stories and discuss with yourselves. So that is something that we have been working on diligently in the development department or team. And then also coming up for June Awareness Month, this is going to be your opportunity as a community to not just raise awareness, but to raise awareness through raising funds for your favorite nonprofit. So coming in June, we are going to launch a social media fundraising campaign, which will also serve as an engagement opportunity for you to share with your friends, your families, and networks about your diagnosis. If you choose to do so, you'll be able to personalize a fundraising page. It will be a 30-day challenge. We are asking you to challenge your friends and family to donate $30 a day for 30 days. for the whole month of June. And we're going to have prizes, a lot of social media posting and sharing. And we just really look forward to you guys participating in this is going to be our signature fundraiser for the year. So that's what we are working on. And I look forward to connecting with each of you. Thank you.
Hi, everyone. I'm Caroline Boline, the National Director of Strategic Impact and Investment. And as Craig mentioned, there's so many ways that we're trying to, provide ways to engage with partnerships and get involved with the community. And one of those really special ways to give back to MGFA is by honoring a loved one. So we have a new-ish opportunity to participate in our online community virtual memorial garden. So if there's somebody that you think about that you want to honor in that way, it's a virtual garden. You can go into the online community and see their name recognized. So definitely, if that's something that resonates with you, is a great way to give back to MGFA and honor somebody that you love. We also have our Partners in MG Care program, which this year we're expanding and growing. So those of you who aren't familiar with our Partners in MG Care, it's the physicians that we work with, neurologists, but we'll also be expanding to include other types of care providers that would be beneficial to be continuing to learn and engage with MGFA. So be on the lookout for that in the coming months. We're going to be trying to reach more patients in more geographic areas by providing a more comprehensive list of partners in MG Care. So, and all of us are always available as a resource. If you have questions or have, a special interest in a way to make an impact, we're always here for you. So thank you.
Okay. All right. This brings our conference to an end. And I just want to say to you guys that this was really a very powerful few days together. It really meant everything to be able to come together. As I said on day one, we tried to stay as connected as we possibly could in the last 3 years. But it's been 3 long years, and here we are. And we just can't thank you guys enough. And I really appreciate all of you who have come up to me and shared your feedback. I know how much you appreciate the coming together like this, and to hear from you how much you've learned and how much you've enjoyed yourselves and how good this has been for your soul. I get that through and through. And I appreciate you sharing those thoughts and sentiments with me, which I've gone back and shared with the team so they know. We don't have to wait until next year's conference. You just heard from the team. We have so many other ways to come together should you be able to get to some of those things. And if not, let's hear from you. If there's something you'd like to start up in your community, please let us know. We're not going to wait on it. We're going to want to have a conversation and move things forward. We're pretty good like that. So I hope that you all learned a lot, enjoyed yourselves tremendously, and I hope you're able to rest too and have some downtime. But just thank you so much for the support. Really, I think this has been a tremendous conference. I do want to thank again all of the speakers. Gosh, we can't possibly plan this conference and have it come together without phenomenal speakers with just fantastic expertise who are willing to get up here and engage and then freely answer your questions. And so thank you to all of the speakers. Thank you to all of our sponsors, certainly around the room and in the hallway. We had the most amount of support we've ever had for a conference. So I do want to thank all of our partners. They do support us year round. So that's quite significant. Anytime we ever go to them with anything, they're open to it. And we just really appreciate that tremendously. And lastly, I always like to do this. I do want to thank the hotel, because they were our partner and they did plan with us for the last year or so. And I know nothing's ever perfect, but we hope that things for the most part are pretty seamless for you here at the hotel. And certainly next year, as we shared, we'll see you in Tampa. Finally, I was talking about how special it is to come here to and be together, and it's been 3 years, but could not go home without acknowledging that our previous CEO, Nancy Law, this was her favorite event. And she would have loved to have been here. She passed away on September 23rd, 2021. And I know the date well because it's my birthday. And she would have been so proud. And I don't just mean of the MGFA. She would have been so proud of all of us that we came together and that we learned together and that we connected and that we made the most of our time and that we told each other how we felt, because she was big on that. So from the bottom of my heart, thank you. I send you nothing but love. Please keep in touch. We're a small organization. Reach out. The door is open. And thank you for being part of our extended family. Take care.